Good morning. So, how to read radiology in ICU? This lecture is going to be a discussion on commonly used radiology which we come across in our ICUs and which can be asked in various examinations. We'll start with chest X-ray. The routine chest X-rays which are obtained in the radiology department are in the PA views. But in the ICUs, the optimum view is AP view since our patients are supine. So this is the difference between how PA view looks and how AP view looks. Because of the anterior projection of the X-rays, you see this widening of the superior mediastinum. There is magnification of the heart. The scapula, they obscure the lung views because it is difficult to rotate the scapula laterally. You see little horizontal alignment of the ribs, and you will see some interstitial infiltrates also because of the underinflation of the lungs in supine position. So this is how a normal AP chest X-ray looks. The ideal chest X-rays, the characteristics, it should be obtained in adequate inspirations. What is adequate inspiration? Adequate inspiration is seen when the diaphragm is intersected by 5th to 7th anterior ribs in the mid-clavicular lines, and which is usually obtained when there is full inspiration. Rotation, there should be ideally no rotation, and how you determine the rotation? You look at the medial ends of the clavicle which should be equidistant from the center of the spinous process of thoracic vertebra. Penetration, there should be well penetration, and how you look for penetration? A well penetrated chest X-ray is one where the thoracic vertebra are just visible behind the heart. So the problems with ICU X-rays, they are obtained in AP view, so you do not meet the ideal criteria. There is magnification of anterior structures, as I've said, of the heart, clavicle and the sternum, and supine positioning, it also widens the mediastinum due to gravitational effects. We'll start with tubes and lines. ET tube, this is the common tube which we see in most of our patients. So what is the safe distance of the tip of ET tube? The safe distance is 5 centimeters above the carina, and to be more precise, the maximum allowed distance is just 2 centimeters above the carina, which allows adequate extension and flexion of the neck without risk of endobronchial intubation. So in this chest X-ray, this is the magnified image. You can see this is the carina, this is the double lines are the endotracheal tube, and this distance from the tip to the carina has to be between 2 to 5 centimeters. We all know the hose goes where the nose goes. If we extend the neck of the patient, the tube tends to come out. If we flex the neck of the patient, the tube tends to go in. So it moves by around 1.9 centimeters in or out with the extension and flexion of the neck. So we keep the distance at around 5 centimeters and the maximum up to 2 centimeters from the carina. So how far can an endotracheal tube move with extension or flexion of the neck? It's 2 centimeters. What is the correct position of NG tube? We all know NG tube has to be placed below the diaphragm. Here you see the beads of the NG tube which has to be lying below the diaphragm in the gastric shadow. Another common line, central venous catheter. Theoretically, the ideal location of the tip of CVP line is between the most proximal valves of the subclavian or the jugular veins and the right atrium. But on chest X-ray, how do you look at the ideal position? The tip of the line should be located 1 to 1.5 centimeters above the carina. So this is trachea, carina, and the tip of the catheter should lie 1 to 1.5 centimeters proximal to the carina. PA catheters, we all know they are introduced percutaneously into the venous system. First they are advanced into the right atrium, then to the pulmonary artery using the flotation technique, and then the balloon is inflated and wedged into the branch of the pulmonary artery to measure the pulmonary capillary wedge pressure. Now the position on X-ray, the rule of thumb is the catheter tip should be within the mediastinal shadow Placement more distally would increase the chance of it lodging it into a smaller distal branch, leading to pulmonary infarction or vessel rupture. So on chest X-ray, you can see this is the pulmonary artery catheter, and the tip of the catheter is within this mediastinal shadow. It should not go beyond this shadow. What else do you see in this X-ray? These are the sternal wires. So probably this patient has undergone a CFBG. Now the thoracostomy tubes. Now it is difficult to determine whether the thoracostomy tube is placed anterior or posterior to the lung on a single chest X-ray AP view. What is the correct position? The correct position, the tube has to be, all holes, all fenestration should be within the thoracic cavity, so as to have a proper drainage of the air. How do you see on the X-ray? The last side hole in the thoracostomy tube can be identified by interruption in the radio-opaque line. So you have to see for that interruption, and which has to lie within the thoracic cavity and not in the chest wall or outside. If the interruption of the line is lying within the thoracic cavity, it's in appropriate size. If not, you can see the evidence of subcutaneous air or misplaced tube should be suspected. This is how it looks on X-ray. You can see this fenestration. This is the breach in the radio-opaque line. So this means the last hole is within the thoracic cavity. So this is the optimum position of the thoracostomy tube. Now something about pacing leads. You know the pacing devices, they are introduced either via a cephalic vein or a subclavian vein, and which the lead lies in the apex of the right ventricle. So the tip of the cardiac pacemaker should be at the apex, and there should be no sharp angulations along the length of the pacemaker wires. So this is a pacemaker device. You can see this wire is going all through the lung, and the tip is lying at the tip of the right ventricle, and there is no sharp angulations or bends in the wire. IABP, you all know about IABP. It's a critical, the positioning of the IABP balloon is critical so as to prevent occlusion of major vessels and to prevent complications, and where ideally the catheter should lie in the region of aortic isthmus or the left vein bronchus. And obviously above the origins of celiac trunk and the superior mesenteric artery, so as to prevent their occlusion and leading to ischemia. During diastole, we all know the balloon inflates, and which appears as fusiform air containing radiolucency, provided the X-ray has been taken in the diastole. Here, this is how the tip of the IABP balloon looks like. It should lie at the level of left bronchus, or to be in simple words, it should lie at the level of carina below the aortic knuckle. And if the X-ray is taken in diastole, you will see a hyperlucent balloon, fusiform balloon lying below the tip of the balloon. Now, moving to the lungs, pneumothorax, we all know the air tends to rise in the non-dependent areas, and it depends on the position at which level the X-ray has been taken. So the air takes that position. In the ICU patient, the diagnosis of pneumothorax is often made in the supine position, and in supine position the air would rise anteromedially. And if there is apical layer in supine AP view, that means there is a large pneumothorax. Deep sulcus sign, it is usually seen in AP view in the patients in which the X-rays are taken in the supine position. There is anterolateral extension of the air into the costophrenic sulcus, so which increase in radiolucency of the costophrenic angle. What do you see here? This is a large pneumothorax of the left side. This white line is the pleural line, which is the visceral pleura, and you can see a large pneumothorax occupying a major part of the thoracic cavity. What do you see here? Sorry? Yeah, this is left-sided pneumothorax, and you can see the wide pleural, visceral pleural lining lying here. So this is pleural edge and there is pneumothorax at the apex of the left lung. This is what is deep sulcus sign. There is this coastophrenic angle is deepened because of the presence of air in the anterolateral part of the lung cavity. And this is the ICD, and this is optimally placed because you can see that the hole is lying within the thoracic cavity. What else you can see in this chest X-ray? There is Rice tube. What else? Yeah, the NIV mask with the tubing. Tension pneumothorax, though it's a diagnosis of, it's a clinical diagnosis, but when there is tension pneumothorax, the findings which you see on the X-rays, there is, because of the tension, there is flattening of heart border, there is flattening of adjacent vascular structures, there is mediastinal shift towards the opposite side and diaphragmatic inversion. Pleural effusions, or as contrast to air, the pleural fluid, it tends to accumulate on the dependent positions. So in supine position, it first accumulates in the posterior basal space, and with increasing amount, it increases towards the lung base, and then the contour of the diaphragm is lost and CK angle may be obliterated. This is a common finding, subpulmonic effusion, which is pleural effusion at the lung base, which we see commonly in our ICU patients. It could be because of the atelectasis, pneumonia, the other etiologies. So on the chest X-ray, a subpulmonic pleural effusion appears as raised hemidiaphragm with flattening and lateral displacement of the dome. This is how it looks like. There is obliteration of diaphragmatic shadow. It appears to be pulled up, and there is haziness at the angle of the coastophrenic angle. What is this? This is large pleural effusion leading to meniscus sign. You can see this meniscus sign here, which is a concave surface at the top of the white area. This is because of accumulation of large amount of pleural effusions which need to be drained. Pulmonary edema, to start with, it is interstitial pulmonary edema, where you see there is loss of definition of large pulmonary vessels, there is appearance of septal lines, there is interlobular septal thickening, diffuse reticular pattern, and peribronchial cuffing. These are all the findings when there is interstitial pulmonary edema. And you all know about Curley's A lines and Curley's B lines. They represent interstitial edema. Curley's A line, they range from 5 to 10 centimeters and they extend from hilum of the lung to the periphery. Whereas Curley B lines, they are relatively small in size, 2 centimeters, which are seen in the periphery and they extend to the pleura. There are Curley C line also, which are multiple small septal lines which are seen throughout the lung cavity. Then when pulmonary edema increases, it involves the alveoli also. So in alveolar edema, you see bilateral opacities which extend in fan shape, and we all know it is called as bat wing appearance. So, and when edema further worsens, the opacities become homogeneously, it involves homogeneously both the lungs, and these dense opacities may contrast with the air-filled bronchi, which is normal aerated when the parenchyma are invisible. So this is how a bat wing appearance look like, and it means that patient has got alveolar edema. This is what I was talking about, Curley's A lines. They start from the hilum, extend to the periphery. They are little bigger in size. Curley's B lines, they are smaller in size. They are seen at the peripheries and they go towards the pleura. Now something about collapse. We all know that collapse that produces the loss in aeration of that part of the lung, and it tends to pull the trachea towards the side of the collapse. In right upper lobe collapse, you can see that there is no aeration. This is all hazy, and you can see trachea is pulled towards the side of the collapse. So this is how a right upper lobe lung collapse looks like. Right lower lobe collapse, again right lower lobe collapse, there is loss of aeration and the diaphragm of this side is pulled up and there is loss of cylinder. Left upper lobe collapse, again it will produce the pulling of the trachea towards the side of the collapse. One sign called Luft-Trickle sign is described, which means there is translucency around the aorta, which is because of the interposition of the aerated segment of the lower lobe, which interposes between the collapsed upper lobe and the great vessels. So it is the aerated superior segment of the left lower lobe which interposes between the collapsed upper lobe and the mediastinum, and it produces a translucency around the aorta. It is a finding which is seen in left upper lobe collapse. Left lower lobe collapse, again you can see there is volume loss similarly which was seen on the right side, and there is elevated left hemidiaphragm. Now ARDS, the most common chest radiograph findings are bilaterally, predominantly peripheral, somewhat asymmetrical consolidation with air bronchogram. So this is how ARDS X-ray looks like. Radiologically, there is multiple inhomogeneous opacities bilaterally present, and the most likely diagnosis here is ARDS. What else you see in this X-ray? There is tracheostomy tube. Apart from the other lines, the chest leads and all. Cardiomegaly you usually see on the AP views, it is there, but to determine whether it is a true cardiomegaly or not, you have to find out the cardiothoracic ratio. And how do you find a cardiothoracic ratio? From the center of the spine, you measure the largest distance towards the apex of the left ventricle and the largest distance towards the right atrium. You add these two and divide by the largest this horizontal distance of the chest cavity. If this ratio is more than 5, that means there is cardiomegaly. And how it looks like? It is quite apparent on seeing only that the heart size of the heart is increased and it is more than 0.5 of this total diameter of the chest cavity. So a little about theory, how to answer chest X-rays. You have to say that this chest X-ray belongs to my patient. You have to name the patient and you have to mention the date also. Then you have to tell whether it is a PA view or a AP view depending upon the characteristic of the X-ray. Then whether it is central, and you know whether it is central or not, you look at the right and left sternoclavicular joints which should be equidistant from the midline. Then comment on the exposure, whether the penetration is ideal or not, and if it is ideal, you will see the thoracic vertebra just behind the shadow of the heart. Then you have to follow a systematic pattern. You either start from out to in, from bone to lung and lines, or you can start from within. So any of the pattern you can follow. Comment on the lungs, then comment on the consolidation, atelectasis, pulmonary edema. Comment on between the lungs, the heart size and the mediastinum. Comment on outside the lungs, pleural fluid, pneumothorax, rib fracture, emphysema, and then comment on the devices which can be there. Now what do you see here? A patient is intubated and you notice decreased breath sounds on left side. What does the chest X-ray say? There is right endobronchial intubation. You can see this tube is going towards the right bronchus and there is some loss of aeration on the left side of the lung. Patient started to desaturate once the feeding was initiated. What does the chest X-ray say? You can see the rise tube is lying in the left lung. So it is NG tube in left lower bronchus. What do you see here? What does this arrow indicate? The central line is pushed in too much. It is lying within the right atrium. And what is the ideal position? It should lie just at the junction of SVC and right atrium, which is 1 to 1.5 centimeters above the carina. So the CVL is in right atrium. What do you see here? This is pulmonary artery catheter which is lying too distally in a smaller branch. So PA catheter in distal branch. What do you see here? This is actually a skin fold which is mimicking pneumothorax. And how do you differentiate between whether it's a skin fold or a pneumothorax? You look for bronchovascular markings here. If there are bronchovascular markings, it is most likely it is a skin fold and not the pneumothorax. So it's a skin fold which is mimicking pneumothorax. What is this? See, now on X-ray it's difficult to comment what is the exact pathology here, but you can see a wedge-shaped opacity which could be infarction, which could be consolidation, and which could be a loculated pleural effusion. So you have to confirm with the CT or the ultrasound findings. So this was a loculated pleural effusion which can be confused with infarction or consolidation. A patient presented with hypotension and severe abdominal pain, what does the chest X-ray say? Yeah, radiologically there is gas under diaphragm which could be because of a perforation of a bowel. So this is, you have to locate the diaphragms. This is the gas which is under the diaphragm, and here you are seeing a tubing which could possibly a oxygen tubing which is lying over the chest. What do you see here? Yeah, there is consolidation of right middle lobe. Right upper lobe. See, it could be collapsed, but you can see trachea is lying in the midline. It is not getting shifted, so it's most likely right upper lobe consolidation. Now emphysema, you all know there is hyperinflation. Because of hyperinflation, there is flattening of diaphragms, there is reduced the lung markings, and there is peribronchial thickening. So this is how a emphysematous lung look like. You can see it is all hyperinflated, diaphragm is pushed down, and you can see reduced bronchovascular markings. Now a patient is a known case of tuberculosis and had hemoptysis. What does the chest X-ray say? Yeah, there is a cavity on the right side of the lung if you see clearly. Apart from there are increased bronchovascular markings. This is a thick walled cavity which is lying in the right side of the lung. So this is right lobe cavity. Patient had swelling all over the face and chest after 10 hours of mechanical ventilation. This is quite evident. This is subcutaneous emphysema. And what is the management? Probably it is because of the high pressures. There is pneumothorax which has led to subcutaneous emphysema. You have to place the thoracostomy tube, and sometimes you may need to place more than one thoracostomy tube because the ingress is more and the egress is less. So this is massive subcutaneous emphysema. A little about lateral cervical X-rays which we commonly encounter during trauma patients. You have to look for three lines, the alignment of three lines. This is anterior line which is anterior longitudinal ligament, this is posterior longitudinal ligament, and this is spinolaminar line. There should be alignment of all these three lines if the X-ray is normal, and it normally follows a lordotic curvature. Again, optimum X-ray is obtained if you see C1 to T1. All from C1 to T1, all vertebra and the spine are visible. And what else you have to see? You have to look at the disc spaces. The height should be approximately same of all the disc spaces if there is no dislocation or the avulsion. And you have to also look at the soft tissue which is lying anterior to this vertebra, because of the fracture there could be hematoma, there is misalignment of this space also. Normally you can see it tapers to C4 and then from C4 it gradually widens. So if there is any distortion in this space, you may look for any pathology here. Now the CT scans. A basic about CTs, air looks black, whether it is present in the trachea, in the colon, pneumothorax, anything, and fat and CSF, they look almost black. Bone appears white, and the other structures, they appear in different shades of grey. So some facts about head CT. Bone, we know white. Hematoma, it depends on the age of the hematoma. Acute hematoma is hyperdense because of relative density of hemoglobin molecules. As it ages, it becomes isodense, and when it becomes chronic, it becomes hypodense as compared to the brain parenchyma. White matter is darker than the grey matter, and CSF appears black. So with these basics, we will comment upon the X-ray, the CTs, head CTs. This mnemonic has been given to remember or to make the head CT read easy. The 6 essential sections of the head, they have been related to they have been given 6 terminologies. As we start from the base of the skull to the top, they appear as X, star, Mr. Happy, Mr. Sad, worms and beans. So you can remember this way. You see how. This is the first section which is taken at the base of the skull. You can see these are globes, these are temporal lobes, here lies the brainstem, and these are the cerebellum. So this is the first section which you get when you take the section at the level of the base of the skull. So you can relate it to a cross. This is a cross. So the first section is cross, where you see the frontal lobe, the temporal lobe, the cerebellum, and here you see the brainstem. As we go further up, we start seeing frontal sinuses. The frontal lobes are already there. You see temporal lobes. Now this is the suprasellar cistern, which appears as a star shape. It is not very clear here, but it is star shape, which is suprasellar cistern, and basilar artery, it lies here. And then start coming the 4th ventricle. And this part is pons and medulla. So you can relate it to a star. This is a star which is a suprasellar cistern, and you can see this 4th ventricle here. So a section above, you start seeing this cistern and the 4th ventricle. As you go further up, you start seeing the falx cerebri. The frontal and the temporal lobes were already there. Now we start seeing the frontal part of the lateral ventricles. This is calcified pineal gland, and these are the choroid plexus, which appears to be calcified because they are appearing white. And here lies the thalamus. And these are the occipital lobes. So this is Mr. Happy. Because of this quadrigeminal cistern, the anterior horn of the lateral ventricles, this appears like a happy face. So you can remember it this way. As you go further down, you see Mr. Sad. There appears occipital horn of the lateral ventricles. These are the anterior horns of the lateral ventricles, and the other structures remain the same. As you go further up, you start seeing worm appearance. This is because of the body of the lateral ventricles and some part of the posterior lobe of the lateral ventricles. So same falx cerebri, the right frontal lobe, you can see Sylvian fissure here, the temporal lobes, choroid plexus, and the occipital lobes. So it appears like worms. As you go further up, Mr. Bean, you just see the 2 parts of the cerebrum. This is falx cerebri, this is superior sagittal sinus, and it appears like the bean. What do you see here? Yeah, this is dense MCA sign, which is suggestive of hyperacute stroke. So this is hyperacute ischemic stroke with a dense MCA sign. What is this? This is large ischemic stroke involving the left middle cerebral artery. And what is the treatment here? We do not thrombolize this patient. Why? Because it is a contraindication, because it has involved more than 1/3 part of the hemisphere. So about acute hemorrhagic stroke, as we have told that acute, it appears hyperdense. As it ages, it becomes isodense and then hypodense. There will be surrounding edema which results in loss of gray-white differentiation. There will be mass effect which leads to compression of the sulci, the ventricles. There could be midline shift and there could be reduction in size of basal cisterns. How do you comment on this, CT? Yeah, there is intracerebral hemorrhage and it is surrounded by edema. So, acute parieto-occipital intracranial hemorrhage. What all do you see here? Yeah, there is midline, there is intracranial hemorrhage leading to mass effect, midline shift. You can see effacement of ventricles and some intraventricular extension also. So, you have to thoroughly comment on a CT when you are given in the exam. This is acute hemorrhage at MCA territory with mass effect and also intraventricular extension of blood. Any comments? Which area is this? Thalamus. So this is thalamic bleed with intraventricular extension. Now a little theory about SDH. You all know SDH lie between the dura and the arachnoid membrane of the brain. Blood is seen over the cerebral convexities and beneath the temporal and occipital lobes. Remember to differentiate it from EDH, they do not cross the midline. This is the characteristic of subdural hematoma. So this is acute subdural hematoma. You can say its characteristics. There is peripheral high density crescentic fluid collection, a concave inner margin, a convex outer margin, and you can see there are signs of mass effect leading to effacement of the ventricles. So this is acute SDH. So after 1 to 2 weeks it becomes isodense, and on further aging it becomes hypodense with or without mass effects depending upon the progress of the hematoma. So, what is this? This is clonic SDH because it has now become hypodense as compared to the brain parenchyma. Now, EDH, they arise between the dura and the skull, and they are biconvex. They were the SDH were concavo-convex, the EDH are biconvex, hyperdense elliptical condition, and they do not cross the suture line. So this is how a lenticular shaped, biconvex shaped acute EDH looks like. Now a patient presented after seizures and severe headache and intolerance to bright light. He also has complained of such headache few days back. What does the CT reveal? Yeah, it's subarachnoid hemorrhage. You can see the blood in the sulci. Again, it's subarachnoid hemorrhage. You can see blood in the sulci and the sylvian fissure. A 65-year-old female presented with altered sensorium and disturbance of gait. He also had episodes of vomiting and blurred vision in last few days. What does the CT reveal? Yeah, it's hydrocephalus. And here you can see a CSF ooze or the edema around the ventricles also. So, enlarged ventricles, because of the enlargement of the ventricles, the sulci get small. There is edema or the periventricular ooze of the CSF. A 70-year-old male was unconscious for 24 hours after a CPR. His EEG showed severe degree of electrophysiological depression. What does this CT reveal? Yeah, there is loss of sulci gyri, loss of gray-white differentiation. So this is, this is edema. So this is cerebral edema. So here you can see as the edema increases, the size of the ventricles becomes small, the sulci are effaced, and there is loss of gray-white differentiation. So the key features are there is loss of gray-white differentiation, sulci and ventricles become effaced because of increased brain volume with the fluid, and later there is development of hypodensity. A patient presents with high-grade fever, altered sensorium and seizure. What does the CT say? Yeah, there is a ring enhancing lesion, probably it's a contrast enhanced CT. You see a ring enhancing lesion, and the DDs. It could be abscess, it could be toxoplasmosis, lymphoma, anything. Could be neurocystic sarcosis also. So here it was probably a abscess. A 65-year-old female operated for CA colon 6 months back, now presented after seizures. What is the most probable diagnosis? Metastasis, because she had an history of CA colon. So how to interpret CT? You have to follow a mnemonic ABBCS. A is for asymmetry, B for blood, B for brain. In brain you have to look for the densities, whether hyperdense or hypodense, any displacement, midline shift, gray-white differentiation is minted or lost. CSF planes, you look for cisterns, sulci, ventricles, you assess the size of the ventricles, look for dilatation, and then the skull and assess for any soft tissue injuries. Something about CT chest. We obtain CT chest in two windows. One is soft tissue window, the other is lung window. So this is a soft tissue window. Here you can see this is ascending aorta, this is superior vena cava, pulmonary trunk, and you can see the two bronchi here, and these are all lungs. And this is descending aorta. Obviously vertebra. This is lung window, where you can see this is ascending aorta, this is pulmonary trunk, same, superior vena cava, two bronchi and the descending aorta. So this is how a lung window looks like, where you see bronchovascular markings and the substance of the lung. A 35-year-old male presented with sudden breathing difficulty after he completed 22 hours flight. He was found to be hypotensive. What is the diagnosis? Yeah, you can see filling effects on both the pulmonary trunk. So this is pulmonary embolism with hemodynamic instability. The management? Thrombolysis. What do you see here? There is no. This is large right-sided pleural effusion leading to collapse of the lung. This is normal lung. This is a part of normal lung. This is collapsed lung, and this is massive pleural effusion. This is how an ARDS CT looks like. You see ground glassing, multiple patchy consolidation with bronchovascular markings. So consolidation with air bronchogram. And you can see a thin rim of right pleural effusion also. What is this? This is pneumothorax. What all you can see here? Yeah, there is an ICD which is lying in the thoracic cavity, a small bulla and increased bronchovascular markings, nodularities. So this was particularly to show you how a chest drain looks on a CT. This is consolidation with bronchial markings. What you see here? Yeah, there are multiple cavities, one large thick walled cavity, small cavities here. What do you see here? If you see carefully, there is a hyperdensity surrounded by a ground glassing. So it's a halo sign which is suggestive of invasive aspergillosis. So this is halo sign, bright density in the center surrounded by a ground glassing. And where do you see reverse halo sign? No, you see it in mucormycosis, where there is hyperdensity in the surrounding and little hypodense within the cavity. This is how a honeycomb appearance look like, and where do you see it? In the interstitial lung disease. Little about CT abdomen. CT abdomen, if you take just at the level of lungs and diaphragm, you see this is how a liver looks like, spleen, this is stomach, this is abdominal aorta, and this is the diaphragm, and these are the part of lungs. As you go down, you start seeing the kidneys. This is liver, spleen, kidney. This is renal pelvis, abdominal aorta, and renal artery is coming out of it. And this is superior mesenteric artery, and here lies the pancreas. IVC, descending aorta, transverse colon, and pancreas. A patient, a known alcoholic, presents with abdominal pain, and after stabilization CT abdomen was done. What are the findings? Yeah, there is peripancreatic fluid collection all over here. Can you see anything else apart from this? There is a contrast, oral contrast which has been given to this patient. You can see it in the colon. So this is peripancreatic fluid collection. And this is when it becomes necrosed, it does not uptake the contrast, so it becomes all dark, like hypodense, it becomes hypodense. This is pancreatic pseudocyst. You can see a cyst lining, and the whole pancreas has been converted into a cyst. A patient presents with severe pain at the back. He is hypertensive and is on regular medication. What is the finding? Sorry? Yeah, there is aortic dissection. You can see a flap here. So this is a dissection flap. A patient presents with high-grade fever with rising liver enzymes. What are the findings? Abscess. There is a liver abscess. Patient presents with abdominal distension with constipation and septic shock. What are the findings? Radiological findings, yeah. There is megacolon, and when do you call it megacolon? When the size of the transverse diameter is more than 6 centimeters. So this is megacolon, and as the clinical history suggests, this is toxic megacolon. A patient presents with abdominal distension with septic shock and high lactates. What are the findings? Yeah, the radiological finding is pneumatosis intestinalis, and it is suggestive of mesenteric ischemia. Very little about ultrasound clips, how they are asked in exams and clinical syndromes. A patient presents with sudden breathing difficulty. The lung scan and cardiac scan were done. What are the findings? First, comment on the lungs. There are multiple B lines, which means the lung is congested. And what do you see here? Yeah, there is severe LV dysfunction. So your diagnosis is pulmonary edema with regional wall motion abnormality because of cardiac failure. A patient presents with breathing difficulty. Yeah, it's a pneumothorax, and what is this? This is lung point. Good. A patient presents with breathing difficulty, high-grade fever, and hypotension. Yeah, this is consolidation showing dynamic air bronchogram. A patient presents with hypotension and desaturation. He recently had history of hip fracture. 2D echo was performed. Now what are the findings? There is RA-RB dilatation, so it's a pulmonary embolism. Thank you.